Hello and welcome to the International Journal of Gynecological Cancer Mentors podcast. As editorial fellows, we are enthusiastic to learn from the leading figures in gynecologic oncology, mentors who have shaped our field through innovation, dedication, and vision. Today, we are truly honored to welcome Dr. Mario Leitao, recipient of the 2025 International Gynecologic Cancer Society Excellence in Teaching Award, recognizing his outstanding leadership, mentorship, and lifelong commitment to surgical education in gynecologic oncology. Dr. Leitao is a US board certified gynecologic oncologist and serves as a member and attending surgeon in the Division of Gynecology at Memorial Sloan Kettering Cancer Center and as professor of obstetrics and gynecology at Weill Cornell Medical College.
At MSK, Dr. Leitao is the director of the Gynecologic Oncology Fellowship Program, one of the largest and most comprehensive training programs in the world. This includes a long-standing and continuously active international training program, the only one in the United States also accredited by the ESGO. In addition, Dr. Leitao leads the Minimal Access and Robotic Surgery program at MSK, overseeing minimal invasive surgical training across multiple disciplines. As an early adopter of robotic surgery, he helped establish MSK's robotic program in 2007. Since then, it has grown into a remarkable enterprise. Today, more than 60 surgeons perform nearly 4,000 robotic cases annually, supported by 11 robotic platforms.
Beyond his leadership in surgical education, Dr. Leitao has made extraordinary contributions to research across all fields of gynecologic oncology, directly informing international guidelines, redefining surgical standards, and advancing evidence-based patient-centered care worldwide. He has played a leading role in the landmark international clinical trials, including ROC trial, ROINS V2, trial translating complex clinical questions into practice-changing evidence across multiple gynecological diseases. Dr. Leitao is also co-editor of the textbooks Diagnosis and Treatment of Rare Gynecologic Cancers, created to provide the structure, practical algorithms for malignancies where evidence is limited. His patient-centered philosophy is exemplified by his pioneering work in uterine transposition surgery, which challenge traditional oncologic boundaries with fertility preservation. And his commitment to global education is reflected in his service to IGCS, including his role as the North America representative on the board of directors, and his current position as chair of the IGCS Minimal Invasive Surgery Training Program. Through lecture, live surgeries, and training initiatives across different continents, he has shaped a generation of gynecologic oncologists around the world. So with us today are Dr. Ikil Selçuk, Associate Professor at Ankara Bilkent City Hospital, Turkey, Vincenzo Tarantino, OB-GYN resident at Fondazione Policlinico Gemelli in Italy. And so Dr. Leitao, it is truly a privilege to have you with us today, and welcome to the IGGS Mentors podcast.
Oh, thank you so much, and thank you all for such kind words. Doesn't even sound like me when I hear it. Been a long time doing this, so I'm very happy to be here. I'm actually honored that you guys would consider to have me on this podcast. So I'm here to answer whatever questions you like, and I'm happy to stay on as long as you like.
Thank you, Professor. So we can continue with the questions, and we are all waiting for these great answers from you. The first question comes from Leia Abuladze, Tbilisi State Medical University, Georgia.
So my question is, what originally drew you to gynecologic oncology as a career choice? Was there a specific experience maybe or mentor early on that helped you realize that this was the right path for you and the field where you could make the greatest impact?
Yeah, that's a good question. So, I didn't go to medical school even knowing what G1 oncology was. I went to medical school thinking I was going to be a pediatrician, I think. Anyway, I then realized as I did medical school that through rotations, I liked something more surgical. And I also wanted to try at least whatever career I had, make at least an impact, not just on patients, but on whatever field I chose. And so at that point, I thought that like OBGYN in general could be my future goal, because you did surgery, but you also took care of patients. There was room for research. It's an area for a lot of research also there. Then I just realized it wasn't surgical enough for me and maybe not as impactful as I thought I'd be. So I actually thought of leaving OBGYN residency to start a surgical residency. Fortunately, in my first year of this was my first year of residency. I actually started to look for surgical programs to leave OBGYN to go to surgery. Because in the US, as you all know, to be a gynecologist, you have to do OBGYN first, not surgery. I know in some countries it's through surgery, others it's also through OBGYN. But Oncology is very difficult to get in the United States with the match system, especially when I was applying, there was only 40 or 45 spots in the whole country. So it's nothing that you guarantee that you're going to get because you say you want to do it. So at that point, I felt, general OBGYN was not going to be as fulfilling as I thought it would be. So I decided I'd just look for surgery and go into surgical specialty. And then by chance, I met a GYN oncologist who I just started at my residency program, who happened to be from Brazil. I'm Portuguese by nature and by heritage, and I speak Portuguese, and I have family in Brazil. So he had started there. He was actually from Brazil, so he spoke Portuguese, and he happened to be Chinese. So his parents had immigrated to Brazil from China. So we met one night by chance at a bar. We were all going out, and we started chatting. We started talking in Portuguese, and he's like, "How are things going?" I'm like, "I'm leaving GYN. I'm going to surgery. I just don't think this is the right decision for me." And that's it. And he goes, "Well, have you ever thought of going to GYN oncology?" And I'm like, "There's no way I'm going to get GYN oncology. It's just too hard." And he's like, "I think you should look into it." So then I spent a couple months at Sloan Kettering as a rotating resident, in what they call the Brunswick rotation. And I just fell in love with it. And I saw that this was probably going to be the most fulfilling career for me because I could do really great surgery because I love surgery. I could do pretty cool surgery. I am more than just a pelvic surgeon. I'm an abdominal pelvic surgeon, so I operate in the entire abdomen. That's a field, something that I was very interested in. But when you talk about potential impact on the field, I think it really was what made me decide I'm going to do this. So I did everything I could to match into a fellowship, and it was the best. And I fortunately matched at Sloan Kettering because in the US, there's a match system. You interview at programs, and then programs interview you, and then you create your rank list, and then the computer matches you where you're going to go. So it's not like you get a few offers and then you pick one. And some people don't match, especially back then. So I got lucky. I matched at Sloan Kettering, and the rest, as you say, is history. And it was the best decision I ever made.
Thank you. So it was the right place and the right time by chance
Always
coming
is.
up.
Always is. And also one thing that's always guided me in what I do. I'm the first doctor in my family. My parents are immigrants from Portugal and Brazil. None of them went to college. My parents didn't go to college. My cousin was the first to go to college. I was the first to go to medical school. So I had no background in medicine from a family standpoint, but somehow I felt that that's what I wanted to do. I don't know why, but that's just what I felt ever since I was small. And what I've always told myself is that, and this is probably what my dad told me too, is whatever you do, just make sure you do it because you love it and only do things that you love. And that's what guides everything that I do. And things will come. If you love what you do and you're passionate about it, and you do things because you want to do that to make difference, then good things will happen. And that's just really a guiding principle in my life. Like I don't ever do anything that I don't want to do or I have no interest in doing.
Thank you.
Yeah,
Very inspiring. So the next question comes from Lucia Ribeiro from Milan, from the European Institute of Oncology.
Thank you. I think we are moving forward to fellowship. Dr. Leitao, during a gynecology oncology fellowship, trainees often face intense clinical workloads and academic pressure and personal challenge. From your experience, what are the most difficult and challenging situations fellows commonly encounter, and what practical strategies can help them maintain a healthy balance between clinical excellence, research productivity, and personal well-being?
Yeah, that's a great question. And being a fellowship director for a big program for all these years, I definitely have encountered situations, fellows doing well, not doing well. And really, it's really an individual sort of situation as to how fellows succeed and what the challenges are. Obviously, if you're single, you have no partner, that's nothing bad. I'm just saying that's your situation where you're no kids, no partner. That's one situation. If you are married or have a partner and on top of that have children, then that's a different amount of different stresses that are introduced, right? So definitely the stresses are different. I think the most important thing is to seek out help if you're having trouble in any aspect of your fellowship. I have an open door policy myself. I have an associate director, Dr. Long, who we have open door policies. I meet with my fellows regularly. And then if I identify an issue, I try to meet with them as soon as I identify that and talk through to see what's going on. I only see with the work aspect of things, but then if this just happened recently, if you notice that a fellow is not doing as well as you think they should be, I talk to them, and then you find out that they have things going on at home. There's a lot of stressors. They have 3 kids, of which 2 are very young and up all night. So then we have to come up with something on how to make them succeed. I want all of my fellows to succeed, and I just need to know what is going on so I can help them. So I guess that all that is trying to say is that the key is to find support in ways that you find helpful, either through a mentor or being able to talk to someone if you're struggling through. Again, if you're a G1 Oncology fellow, you should have baseline love what you do. So you hopefully want to succeed, and then that should help. I think it's very important to have a family, friend, life balance. Yeah, hopefully you find a program that supports that also and has support for that. We do here. Because we're a large program, fellows can take time they need, and we have lots of fellows to cover, so that helps. It's a more challenge when you're just one fellow a year for 3 years. So I think that you have to kind of dedicate when you're at work to being excellent at work, and then when you're home, being excellent with your friends, and you have to have friends and family for support. Beyond that, it becomes very individual. And don't forget that at the end of the day, and especially as I'm getting older, when you're done and retired, no one's going to really remember you as much as your family and friends. So it's important to keep those relationships healthy. And I think that helps the fellows. The fellows who have the healthiest relationships outside of work are the ones who I see are happier and do better. And of course, there's always little issues that you have to address with each individual fellow and then decide, you have to identify somebody, mentors who you can talk to if you feel you're struggling, and also they can realize if you are struggling, how they can help. And mentors are not assigned. I'm not a fan of assigning mentors. I don't assign mentors to my fellows because that's not really a mentor. Mentors are sought, right? The mentee seeks out the mentor, and the mentor is someone who wants to help you regardless of what it does for them. Whereas if you get assigned, that's really like a preceptor. You get assigned somebody. That's not what you need. You need to seek out mentors that you feel you can connect with on whatever level, whatever that might be, and that you feel they're there for your benefit and to help you. So those are things that you as an individual fellow needs to see and resident need to seek out and not be assigned, because assigned mentors never work. Sometimes you get lucky and they work, but not always. So what I've done here is I don't assign mentors, and what I do is when I identify a fellow that is struggling, I talk to them, try to find out as much as they're willing to tell me what's going on. And then I say, well, who do you think here of the faculty you could see being your mentor? And then we connect them at that point as like they're a mentor where they meet regularly and things like that. So that's how we run it. That's my perspective at this point. Again, it all comes down though to loving what you do and wanting to succeed at what you do. And all the rest usually comes along with that. Maintaining healthy relationships outside of work. Make sure you make time for friends and family outside of work. But at the same time, make sure you also do very well at work and don't, slack at work either, So, and read, always be reading. Again, I say that when you're a fellow, this is a different type of learning. You're an adult now. It's not like, here, read this chapter today, read that chapter today, read this paragraph. You are now an adult. You've been an adult. Now you're doing this because you want to help women with cancer and move the field along. So you should want to learn and be able to learn a lot on your own also. So I don't know if that answered the question.
Yes, thank you. Yes, I can imagine also the people is there, is away from home sometimes and doing well at home, at work. Also, it's a balance to stay away
Yeah.
from home and perform well at work.
So with our international program, especially, that's an even bigger challenge because they're coming into a brand new system. You know, they're coming from a different country where the medical systems are different. Sometimes the names of the drugs are different. You know, how we do things, we're very busy here. People don't realize how busy we are. Maybe you do, maybe you don't. But once you come here as a fellow, you realize how busy we are and how busy the fellows there are. And it's just a different pace. I've had occasional some of the international fellows come early on and say, I don't know if I can finish get through this program. But with that, it's another sort of identifying, you know, you're going to finish. We'll make sure you finish. And what do we need to do to make you finish and finish successfully? So yeah, again, every trainee comes from a different background, different life experience, different support systems, and all that factors into how you mix that all into a successful formula to be successful.
Thank you.
So for the next question, we have Alwyn Matthew, OBGYN resident from Houston Methodist Hospital. So please, Alwyn.
Thank you, Dr. Leitao. This is a good transition to our next topic. It was the mentor-mentee relationship. So what defines an effective mentor-mentee relationship to you? And then what attitudes or behaviors do you expect from trainees who want to grow quickly, responsibly, and sustainably? And then what do you think trainees often misunderstand about what mentors can and cannot do or provide?
Right. So a mentor is, like I said, someone that you seek out. It's an organic kind of combination. It's not an assigned. I know some places assign mentors. I just am not a fan of that. I don't think that's what a mentor is. You can assign preceptors or an instructor. So your mentor is not there to teach you how to be a GYN oncologist in terms of how you treat cervix cancer, how do you treat ovarian cancer. Did you read this? Your mentor is there to sort of guide you as a whole through your career and not just address sort of the lapsing knowledge or maybe surgical issues, but also what do you need to do to get better at those things from a core sense, right? And they're there to help you get better without it being something that makes them better in terms of, you know, they're making you write papers or do, like, you know what I mean? That's not what a mentor ever should do is, you know, well, you write this paper for me, you know, or whatever. That's not a mentor-mentee relationship, okay? And I think that also if you have assigned mentors somewhere, you need to, and it's not working out, you need to speak up and say, this is not a good relationship. This person is not interested in me so much as just they're interested in doing a job that they've been assigned. So it's usually very obvious when somebody's really interested in you and your career and making it sure that you get better and succeed versus someone who's just giving you tasks to do and going through just checking a box that, yes, I met with them every 4 weeks and we talked about, you know, how to operate and stuff like that. That's not what a mentor is. So we don't even have that here. Again, I think it's different from when you're a medical student, become a resident versus resident to fellow. Fellows, again, you've been through 4 years of training. So, you know, they're highly selected individuals, at least here in the US with our sort of interview process. So you already are selecting from a group of folks that are quite responsible and have already been successful in their residency. So now it's just sort of fostering this further. I think, again, when you become a resident, it's a different situation. You went to medical school. Now it's, you know, you're exposed to all kinds of things. Now you're going to focus on one thing. Hopefully you've picked the thing that you really are passionate about. But like I said, I almost left to go to surgery. Don't ever be afraid to make a change. It's worse. You know, oh, I did 2 years of OBGYN. Now I'm going to see if I match and do 5 years of surgery and then maybe 3 years of fellowship. And I'm like, this sounds so long. But guess what's worse? 15 years later, doing something that you regret doing. Okay. So that's what you have to think about. Always be honest with yourself that you're picking a career that you want to really do and are passionate about. And if ever you feel that that's not the case, you really need to reevaluate what you're doing. I hate when doctors tell, you know, young people, oh, you know, I don't go into medicine. It's the worst thing ever. Then that's their problem. They picked the wrong career then. Not, you know, this is a wonderful field and I love what I do. I would do this all over again. You know, for me, it was 4 years of residency and 4 years of fellowship. And that went quick. If I hadn't done that and I stuck with OBGYN 25 years later, I'd be like, why did I choose this field? I'd be looking to retire already, and not happy as I am, and not have contributed probably. Oh, who knows? But you never know, I guess. But I think that's, again, it comes back to loving what you do, being passionate about what you do, and everything falls in place. If you ever feel you're doing something that you're not passionate about, you should need to reevaluate what you're doing. It can be as simple as not working on a project, saying no to projects and tasks that you aren't interested in. That's something that's hard for especially younger trainees, even my fellows. So I provide a resource. I tell them if any faculty approaches you about doing a project or a task that you feel is either just busy work or of zero interest to you, and you don't feel you should be able to tell them no respectfully. But if you feel on that hard, just let me know and I'll talk to them. So I think when people are forced to do things that they don't want to do, or well, some things you have to do because of still work, but sort of developmental things, that's not a learning environment that succeeds. So and having someone you can reach out to be your sort of advocate, that's that mentor thing. They're there to, I don't feel comfortable telling so and so that I don't feel comfortable doing this. You go to your mentor and say, how do I approach this? Can you help or guide me on how I should respond to this ask that someone asked me to do? So that's what a mentor is all about.
Thank you, Professor Leitao, for the great answers and great replies. The next question comes from Beatrice Sarta, Oncology Center of Latvia.
Hey, so we know that the robotic surgery program at Memorial Sloan Kettering grew from a small group of surgeons performing just over 100 cases per year to a high-volume program with 60 surgeons performing around 4,000 cases in 2025 with 11 robotic platforms. When surgical training scales to that level in a demanding environment like MSK, how do you protect quality, not only in terms of surgical outcomes, but also teaching and working collaboration? Which systems or strategies have proven most important in maintaining high standards? And what are the most common pitfalls that large, rapidly expanding training programs should actively try to avoid?
So, great question. I mean, obviously the robot stuff has been a passion of mine for a long time. We are going to get 2 more robots actually in next week, so we'll have 13 robots. We're getting 4 DV5s here, trading out 2 of them and keeping, so we'll have 2 extra. So we'll have 13 platforms here as of next week. I oversee the whole program for the Department of Surgery, so it's multi-specialty. So I have that role, and there what we do is there's a lot of ways to answer this question. It depends on the perspective. Are you starting a new program? Or how do we do it now in a large program? Because things have changed over time and we've done different things as we grew. Initially, it was just myself, just myself actually started on GYN, and then there was a couple urologists and some thoracic surgeons at the beginning in 2007. And we had 1 robot. And then as I took over programs, we started adding more services. So there was a process there of bringing on new surgeons. And then obviously the trainees. So in general, when you're in a training program and you're doing new things, the surgeon, the faculty has to be proficient at it before they can start teaching. So you can't have good teaching if you're not good yourself at what you're doing. So when you start new programs, unfortunately, the trainees during that new growth often suffer a little bit because they get to do less. And that's what I tell my fellows when they leave. You've been a fellow and a trainee with me or someone like me, kind of there, always showing you what to do. When you go out, you're not going to just start letting residents do everything. You have to become proficient on your own now. So that's a learning growth. And you have to talk to the trainees you're going to work with that. At the beginning, you may do more of the procedure than you're going to allow them. And that's okay. You've always been under somebody. So at a place like ours, every fellows don't operate by themselves here. There's always faculty there. We do have some structured initial training that we make them all do. So for the whole Department of Surgery, we have sort of introductory fellow requirements across all the services that have to do some simulator time, dry lab time, things like that. And then it's really up to the individual services to decide how they train their fellows. So as a GYN person and a fellowship program, it's different than if you're in a residency program because most of our fellows already come with robotic experience in the US because they've already experienced it in residency. So it's different. Earlier on, it wasn't. So earlier on, we would sort of, I used to track every single part of the procedure in a data form and how much of it the fellow was doing. I would make the nurse note everything down. So then I could track, and then we published early on. So my publications were on introducing this to a training program. We would then see, you know, what was the OR time when the fellow did 50% of the cases, and or how long did it take to get there? So the key here is you have to just track everything, and it's slow implementation. One, the faculty has to be proficient at it, and then they can start teaching, and then you have to track everything. We're very good in tracking everything here. All of our database, as many people know, we record everything around here. So I maintain the robotic database, and I stopped really this process when we hit 5,000 robots. We're at like 12,000 now cases. So those first 5,000 is when I published a lot of our experiences in introducing this. Initially, was introducing and training the faculty here step by step. So initially, I trained. Another surgeon 6 months later came in. I didn't train it. I've already been trained elsewhere, but another surgeon came on who had some robotic experience. So then the two of us, once we started establishing this with the OR staff, we then brought in the other surgeons on the GYN service slowly. And so we would take time out of my schedule to go operate with them. Then when they were comfortable, they did a few cases and they started training the fellows. So the fellows here at the very beginning of our program basically watched a lot as faculty were learning, especially when I started training the other faculty. So it's a complex thing when you, especially when it depends on the program you're at, how many trainees you have, how many faculty, but the key has to be the faculty needs to be proficient at whatever they're going to do. So the unfortunate thing with that is when that happens at the beginning, fellows and trainees get a little less of an experience other than seeing how to do something new. And then, you know, now that we're in this sort of, I mean, the fellows do finish with 300 robot cases. They like 200 MIS non-robot and another 300 open cases here when they're finished. So it really is left to the individual faculty to decide how they train the fellow on the robotic platform or in any surgery. So I can only speak to myself, is that if I have a new fellow, brand new, then, you know, my first few cases, I kind of just let them do parts of it just to see how they move their hands, right? And then based on that, the next case, I let them do a little more. And then I just tell them, let me get you through here. So it's an individual way of teaching people. It's hard to put down this hard, fast systems thing. If you're training residents and you have this capability, of course, you can try to do dry lab requirements and they have to meet certain skills and pass certain things. I don't have that kind of flexibility here because day one, our fellows are operating right from the beginning. So really a lot of this will depend on the environment you're operating on. And there's lots of great ways to do this at other places. I guess the common pitfalls too, some of the common pitfalls is one, faculty who aren't proficient trying to train people, because that's just a disaster. Two, if you're building a whole program, forgetting training, just building a program, a huge pitfall is just to bring in too many surgeons at once onto a new device. You have to do it stepwise over years, even to get to a program where we are now. You can't just say, you know, we have one robot, we're gonna train 15 surgeons at once to use this one robot. That doesn't work. So I can definitely speak to more specifics areas of programmatic growth and how we introduce fellows, but that's kind of just a broad overview of how I train fellows. I can't speak too much of training residents because we're not a residency training program. And then you also have to track all your data. You don't know what's going on unless you track all your data. You have to figure out a way to do that. I mean, I was back then just a piece of paper. I created a form and we made copies, and there was a stack of them in every room. There was a robot. In every case, we pulled it out, had the data, put the fellow's name, procedure, some OR time, stuff like that. And then we had a box that said percentage fellow did this part, like the right paraortics, the left paraortics, right. Like we broke it down by actual steps of the procedure as to how much the fellow did there. And then we tracked to see what how that was impacting OR times, complications. We found that there was no difference in complications because we're always there and we take over if there's a problem, right? So, of course, none of this will apply to a program that just trains residents who are brand new out of medical school. It's going to be a different training environment. So that's how we've done it here.
Thank
Yeah.
you.
Thank you. Thank you very much for your answer, Dr. Leitao. And always talking about robotic surgery training. So, as a director of the minimal access of robotic surgery training program at MSK, do you see the amount of surgeons operating at highest volume and highest level of complexity? So, what are the non-negotiable competencies a trainee must demonstrate before being considered safe and independent in complex oncologic mini-invasive surgery? And in parallel, as robotic platforms becomes increasingly dominant, how do you envision the role of laparoscopy evolving alongside the robotics in the future era of gynecologic oncology surgery?
Okay. All right. So, how do I sort of steam a trainee to be competent and safe and independent complex oncologic MIS? So, again, a trainee is evaluated by us and not in isolation on MIS and in MIS, either robot or not. They're also doing open surgery with us together. So it's sort of a composite assessment of the trainee's surgical skills. And the nice thing about the robot is that you can translate a lot of your open techniques to the robot because it's more naturally, the motions are similar to what you would do with open a lot of times, whereas laparoscopy, you're trying to work straight sticks, different angles, you're really learning different ways of approaching that area. So, how do we do this? Our fellows rotate every month on different teams. They also go to colorectal surgery. There's an evaluation of the fellow at the end of the month. So I ask that faculty observe the fellows as they're operating and then give feedback to me at the end of the month and to the fellow that then we put a composite together and I meet with them every 6 months, sooner if there's a real issue, but if everything seems fine, we just keep going. And then so that by the time that they're in their final year of fellowship, which is 4 years here, we let them do most of the case, at least the easy stuff, to get a sense that they can do that case, and we sit there and watch. That's what I do, and give little pointers. And then I can usually tell, and they like an endometrium sentinel node mapping is no problem. I mean, we're not doing a lot of complex MIS stuff to the volume where fellows are going to be competent and safe in that. The goal of fellowship is not teach you everything you're ever going to do in your career. It's to teach you who should be operated on, how to deal with complications, your anatomy, your techniques, and then you'll learn stuff as you finish your fellowship. I'm doing stuff now that I never did during fellowship. I didn't do a robot casing during fellowship. I didn't do uterine transposition during, how do
Yeah.
so as a fellow, the goal shouldn't be to do as many things as possible and do a whole volume of things. Your goal should be to learn anatomy. If you know anatomy and you know all the instruments that you're supposed to use, if you know anatomy, you can do almost anything. Because when you really look at other surgeons operate, you realize that's not that hard to do. I mean, reanastomosing a ureter to the bladder is not that hard to do. If you know the anatomy, if you know, it's not that hard. You cut the ureter, you splay, then you stitch it to the bladder, you make a hole in the bladder. It's not that hard, okay? But you have to know the anatomy. And fellows often at the beginning struggle, just lost in the space that we're operating in. So I think I always tell my fellows, they're not going to do none of them's going to do enough radical trachelectomies here that they're going to leave here having done 20 radical trachelectomies by themselves. That's just impossible. We don't do periaortic node dissections that much anymore. So how am I going to say that I don't know. I just know that they can operate. I've taught them anatomy. They know their anatomy. I see them do open surgery, and at the Balkans, we do a lot of things. And then you just say as a composite that they're safe and competent to do G1 oncology. And then you learn as you go. You continue to get better after fellowship, right? Anybody who's doesn't think that they're going to get better after fellowship, just stop learning. So the fellowship is really to teach you how to continue to learn and get better over the next 30, 40 years of your career. So it's not, and since we're an ESGO program also, I do also see the ESGO competencies and logbooks. I mean, that's not really all that objective, to be honest with you. It's very hard to do objective assessments of surgeons. You can use gears, you can use goals, and you can crowdsource and all those things, but I can get my kids to do a video game when they were 8 years old, and they're probably better than some of my 40-year-old partners on a video game, right? Like the simulator. I had my kids on the simulator. I mean, is that really how you assess how good somebody is surgically? Not really, So I think all of us around the world really don't know how best to 100% objectively assess a trainee. It really comes down to just your experience and how people operate and watching people operate to say, yes, this person looks comfortable when they're operating, and there's very little instruction I need to give them. I don't know. I've been doing this so long, but it's kind of at the end of their fellowship, I just look at all their evaluations, my experience with them, and then I say, yeah, I would trust this person operating. I'm always open to
Thank
ideas
you.
too, but every
Yeah.
idea I heard is like, pass some skills in the dry lab or do simulator stuff. I mean, all right, like I said, I can have my 10-year-olds do the same thing in a dry lab. It's a game to them. And they'll probably ace all that. They'll have a 100% score. Does that mean now they're competent to operate? That's not what a surgeon is. It's just competency in doing dry labs and simulator stuff. The surgeon is more, knowing the anatomy, knowing what the complications might be, how to handle complications, how do you handle vascular emergencies during surgery? When should you operate? When should you stop? When should you call for help? Right? All those things I think is what's the core of training fellows, is to train them how to do all those things, not to train them to do 50 radical trachelectomies by the time they graduate. That's just never going to happen. Or to do, I'm giving a talk at ESGO in 2 weeks on portahepatis dissection. All right. How many portahepatis dissections is a fellow going to do here with me that they're going to say, yes, they can do it by themselves comfortably? So I always tell my fellows when they leave here, we do so much, as you all know, but we make it look easy with them. I tell them, when you go out, don't think that you can do this just like we did. Okay. You should go out, especially when it's non-pelvic surgery and you're working the upper abdomen and things like that. You're doing bowel work, bladder work, whatever you think you want to do yourself. You should talk to the other surgical specialties and have a conversation with them that if you don't want to do those surgeries, fine. Just say you'll call them when you're doing surgery and they'll do the bladder or they'll do this or they'll do that. But if you actually want to make it a part of your armamentarium, then you just, like I did when I left here for a few years, I talked to the other specialty and say, listen, I'm doing my splenectomy, like the first one I did when I finished fellowship. I had a surgical oncologist. I called him and said, I'm going to be doing a splenectomy, the bulking, would you be around in case I need help? And he's like, yeah, fine, just call me, right? So, or if you do something different, just work with that surgeon. If you're working around the porta, you're doing the bulkings. When you're out in practice, call the petabiliary, do the surgery with him. Don't leave and let the fellow do it or the resident. Stay there. Operate with that surgeon. After a while, you'll realize it's not that hard to do. It all comes down to anatomy. All this stuff all comes down to anatomy, right? And the only reason we don't do certain things is because we don't know the anatomy or the consequences of doing something, right? So once you can learn that, and now you get from working with other surgeons, then you can do just about anything. It really, but that takes time.
Yeah.
Trust me, when I finished fellowship, I thought I was the best surgeon in the world, super smart. I realize now, all this time later, I wasn't as smart as I thought, nor as good as I thought I was. And, because you gain this comfort level over the years. So it's impossible to learn all that in 3 years of fellowship training. It's just impossible. So you have to learn the core. You have to be super good at the very core, the anatomy, the techniques, the tools you're using. You have to know that robot inside out. You don't just show up and say, how do you use this? Turn the button here. I read the whole manual for the robot. Anytime there's a new, like the DV5, I just went through the whole training for the DV5, which is not that hard, but I know the insides and outs. So if something happens, I can troubleshoot. So that's the key. Like, what kind of sutures are you supposed to use? Like my fellows, that when they finish, are like, oh, what kind of sutures were you using there? Like CT1, like stuff like that. You have to know those things and how to use those things. And then you can just basically do almost anything.
Yeah. So the focus should be to master the basic knowledge, basic techniques, skills, also instruments, all these basic stuff, and then also after the fellowship, during your career, then to apply this basic knowledge in more specific and complex procedures and surgeries.
And seek out help at the beginning when you first go out to practice by yourself. Get senior partners, other specialties to come and help you. I know in some places people say they're not allowed to do colon surgery, or even in the US that happens. That I can't say anything about that. But if you really want to do this all, just call them. And another good thing for training is videotape everything you can. Okay, it's just like professional athletes. What we do is a skill, right? And we're just talking about surgery. Obviously, in the US, GYN oncologists, we also give therapeutics. So my 4-year US fellows are also trained in chemotherapy and therapeutics, and almost all of them go out and do both surgery and chemo and all that stuff. So that's a whole different training part here. But if you're just talking about surgery, it's a physical skill, okay? It's not a drug that's delivered equally. And so anybody who does a high level physical skill, and I always look at athletes in sports, the Olympics are on now. What do? After the event, they go back and look at the video. You know, how could I have made it better here? How can I gain another tenth of a second, right? Maybe my hand should have been turned this way slightly, right? So we're watching those videos. I still have videos on VHS tapes. I don't even know if you know what the VHS tape is, but I have VHS tapes of my first cases when I finished fellowship. They're still in my office here. And I used to go back after every surgery and look at the video and realize that, you know, why was I struggling there? This was so easy. It was obvious that I could have done this here. Oh, I should have done that there, here. You know, and if you have a complication, that's where you learn the most. If you have a complication and then you have the video, you go back and say, "Oh man, that's why." You know, why did I cut? That was obviously the ureter. You know, why did I cut that? You know, so that's how you learn. It's an ongoing process throughout a career. It never ends. Never ends.
Thank you.
Watching videos, if you can, have the opportunity. Open surgery is hard because it's hard to collect open surgery videos, but if you can, it's great. Obviously, with MIS, it's easier. So if you're a trainee, you should ask, can we record his case? And then sit down with the faculty and review it. I do that all the time with my fellows still, especially when they do about half and I do the other half, and we sit down. I'm like, see, that's you there, and that's me there. Can you see the little difference there of how things are going, especially with like traction and opening spaces and things like that? They're very timid and stuff like that. But when you watch the video, you're like, yeah, you know, why was I doing it that way? And then you can see there's an improved growth in there by doing that. So video is very important as a surgeon to capture as much as you can and then sit down and look at what you did after the case.
Absolutely. Thank you for all of your answers.
We have another question on education, and it comes from Anusha Kamat, an associate professor at All India Institute of Medical Science in Nagpur, India.
Hello, Dr. Leitao.
Hi.
With the rapid evolution, of digital health, artificial intelligence, virtual training, and video-based simulation, where do you think surgical education is now headed? And what do you think we can now outsource to AI? And what must remain strictly human?
Yeah. And I just thank you for that. I'm gonna try to address that, although AI is very new. So anything anybody tells you is going to be complete theory as to where AI is going to take us, right? So, and also from the last question, it said about the role of laparoscopy as things evolve. It's all laparoscopy. That's my view. The robot's just a tool to do it. Eventually, every single laparoscopic case will be robotic of some form. I don't know when that'll be, but it will be. So it really doesn't matter. We learned how to do with straight sticks. It'll all just be done with some computer-assisted tools. That's just the evolution of surgery, okay? So for now, there's still a role for it because of access to robots, but over time, it's all going to be computer-assisted surgery in some fashion, and it's all laparoscopy. All right, so digital health. I mean, I've been using ChatGPT, honestly, personally, for a little while now, and I've found that very helpful for like making little apps for like nomograms and apps for certain decision-making stuff, which has been pretty cool, and also helping with my statistics stuff. So I think when AI, especially ChatGPT and all the other AI tools that are out there, they're much better when you have sort of things that are more structured in terms of information, like math, stats, you know, coding. I think that's where it's really going to explode at the beginning. When you start talking about surgical techniques, that I don't know, there's nothing that's going to replace a surgeon anywhere in the near immediate future. How it's going to be used in training, again, we've been doing, like I said, we've been doing video simulation. There's simulators available all over the place. The problem with that, it's a video game, right? You can, like I said, you can have an 8-year-old child do exceedingly well on a video game. It doesn't really, it teaches you some basics, but it doesn't really help you with dealing with the variations in patient anatomy, right? That's something that's very hard to train. Well, the AI now make it more realistic simulations. You can say, make this uterus 15 weeks with multiple fibroids, and now let's try to do this. I think that might be where it's going to come, where your simulators will be much more robust, and you can try to maybe take somebody's. So what we're trying to do here is take somebody's CT scan, they have a big tumor, try to do a 3D recreation, and then try to operate before the surgery on that recreation so that you can anticipate the planes and where you're going to be. So I think that there will be a big role in terms of surgical planning, surgical training, I think for sure, especially as the simulators get better. During doing surgery, I think it's going to be a long time before there's any artificial person taking over a real person. Maybe 50 years, 100 years,
That's good
maybe.
news for us, I think.
Yeah, no,
That's good news for us.
there's
Yeah.
always a need. It's just like the evolution of technology, you know, we don't have ice trucks anymore that deliver ice to people's houses, right? There's refrigerators now. So if you think about that, civilization evolves with the technology, and we learn how to evolve within what our role becomes. Right now, no one really knows what that role is going to be. It's not going to take the place of a surgeon right now. It might augment us. I think pathologists or radiologists are much more worried, and they're more reason for them to worry because that's all pattern recognition, and a computer probably could do it better in terms of pattern recognitions. That's what you're looking at with scans and slides. But when you're dealing with something where you have to make real-time decisions and then alter that decision based on real-time environments and bleeding and things like that, there's nothing in the near future or even 30-year future that I can see where you create a robot that does a surgery. Will it help you identify structures better? Probably. Better imaging systems. But again, you need more than just standard laparoscopy for that, right? So it's going to be an integration of more robotic computer-assisted surgery, right? With the AI built into it. You can only do so much with straight sticks in AI, you know what I mean? So you have to sort of get over that straight stick laparoscopy, that's all laparoscopy is. It's just minimally invasive surgery. We're just making the tools better for you. The costs are prohibitive, but once that starts to not become an issue, no one's going to hold sticks anymore. You know what I mean? Or they're going to have something that's going to make that easier to operate. That's the future of surgery. How long that'll be, I don't know. So again, I think AI will be great for training. It'll get better. I think as surgeons, we're looking to identify structures better, identify the tumor location, the adjacent structures. I think that'll help there with imaging, intra-op imaging, which many of us have been interested in. And again, the training and sort of simulation depends on the environment you work in. In a place like ours where the volume is so high, I don't need my fellows to do a lot of simulation because they're just operating every day. They operate every day of the week. They do 3 to 5 cases every day of the week. So that's different. I don't rely on simulation-based training for them because I don't need to. But if you had a program where the amount of surgery is not as high, I think that's where simulation becomes more valuable to at least give you some additional training and then supplement that with the live training. And I think in a lot of residency programs, that's becoming an issue, especially in OB/GYN, where the number of procedures some of these GYNs are doing is much less than ever before. And so they're not bringing in as many cases. So I think there, a reliance on simulation and sort of virtual training is much more important to supplement the live training, where you go to a place where you do nothing but operate 5 days a week. There's no time to do simulation. You know what I mean? Or AI-based training. And again, I'm very excited by AI. I'm really, I think it's going to make our lives better if used properly. It won't replace a surgeon, not in the near future, not in your career time either, to be honest with you. I don't care what anybody says. That's just not going to be the case. I was at a meeting not too long ago for Medtronic. Yeah, I can say that. And they were obviously they had some people who are doing extra and who have robot companies and are robot engineers saying that the technology is nowhere near to being ever able to replace a surgeon right now. Okay, so don't worry about that stuff. Just try to figure out how you're going to incorporate into your daily practice and care of patients. I think that's what we need to do.
Thank you.
Professor
And no
Leitao,
robot can be a
thank you
mentor. I don't care. There's no robot that can be a mentor. I saw that little part here because I have the questions here too.
Yeah.
If you're relying on ChatGPT to be your mentor, you're going to go down the wrong path because all they do is just prop you up and say things nice to them. They're never going to be honest with you. No matter what you tell ChatGPT, whatever question, oh, that's such a wonderful question. You are so insightful. And here's the answer. So
True. Thank
Thank you,
you.
Professor Leitao, for your great insights on surgical education, mentorship, and relation with the mentor and the mentee. We get too much from them. And the next question is about the career strategy and saying no wisely. Over the years, how have you decided which opportunities were worth your energy clinically and academically, and what helped you say no wisely so you could
Yeah.
focus on the right ones? How you have been able to understand which choices were worth focusing most of your energy, and how you realized those were the right ones to insist on?
Yeah, again, it depends on what kind of career you want to have. If you want to have an academic career or, sort of be involved at the national, international level in societies, I think you sometimes have to say yes to a little more things than you'd like to sometimes just to be involved. But again, it goes back to always really thinking about what you're being asked to do. Is this something you're passionate for? Is there something you can make a difference with this? Is this something that's going to make your life better also? So it's hard. It depends on the environment you work. I mean, if you work in an area and you're a trainee and you have faculty that are not so understanding and they tell you to do something, even though you don't want to do it, you tell them no, it's going to be a problem. What choice do you have there, right? So this assumes that you're in an environment that you have faculty that also understand. So again, like I said here, I tell my fellows, you should always be empowered to say no to something that you have really no interest in. But you can't say no too much either. If you say no to everything, no one's ever going to ask you to do anything. Okay. So it's a bit of a compromise. Okay. I would never do, and I've never done anything just to have a title. Okay. If I'm going to do something, be director of something, it's because I'm going to do a job to make it better, make it great, and then leave it to someone else. Okay. I'm not just going to be somebody to be director of this to just have that title and do nothing with it. Okay. Because I didn't really want to do it in the first place. So again, you have to, assuming an environment where you have folks that understand when you say no, it's not always the case. You really have to say, listen, I'm not quite an area of interest for me. If you have other projects, say I'm working on all these other things, I want to sort of make sure I complete those things first before I do this. If someone says you want to be a director of, I don't know, do you want to be a director of the medical students? Like, I really have no interest in training and overseeing medical students. I have no interest in overseeing something like that. So you just have to be honest with yourself and whoever's asked you to do something. Yeah, it's hard if you work in an environment where it doesn't, it's not conducive to that, where, if you say no, there's going to be a problem. I can't help there. I think also something that being present in terms of a sort of a career where you're involved nationally, internationally, being present at meetings is important. Doing what you guys are doing now is great stuff. Also, being involved as an editorial assistant, that gets you exposure. I think that's great. Reviewing for journals, you'd be surprised at how, the editors are well known, and then they actually know who's reviewing for them and saying yes and who's not, and who's delaying and not responding. I'm a section editor for Surgical Oncology. I know who's not answering to my request for review, things like that. And the ones that are, I'd like, oh, who is this person, and have a little more. Next thing you know, you're being asked to do something else and be involved in something you really want to do and kind of go up. So it's choosing between obviously things you want to do. So there's things that I really want to do, and there's things I absolutely don't want to do. You try to say no to those things. And there's a whole bunch of stuff in the middle where like, yeah, it's okay. I'm not that interested, but I'm not that disinterested. And maybe by doing this, I'm now part of this committee for the SGO or for the IGCS. And now you go there, you participate, people start to know you. Next thing you know, oh, you do this, be director. Maybe you can lead this little program we're doing here. Or when you want to be on the board, you've done all these other things with that society, right? So it's a balance between the two of that. And it also depends on what kind of career you want to have. If you just want to take care of patients, doesn't really matter. You can just do whatever you want, and just make sure you're a good clinician. And residency's quick. Even if somebody asks you to do something and you don't really are interested in it, it's 4 years, 3 years, wherever. I don't know what different countries what the residencies are. I mean, eventually, once you finish residency, they can't do anything to you, right? You're done. So again, it depends on how the question is being framed. Is it just like during residency and now that's it? I'm going to be a clinician and never do anything academic. never be involved on any other larger scale than in my own practice. It's different than if you want to try to contribute more beyond your own clinical practice. And then again, I would always say no to stuff that you absolutely have zero interest and even might hate. I don't want to say what I hate because it might be, not people might not like it, but and I absolutely say no to that. I've been asked to do stuff like even now you have to say no. I say no a lot now also too. When you get older and you do things, you have more flexibility in saying no without reason. I think as youngsters and the younger folks, folks ask you to review journals, articles, write chapters. That's a good learning thing too. Chapters are very tedious, but that's a great learning. Like would never do a chapter now by myself. If somebody invites me to do a chapter, I'm like, I'm gonna ask a fellow, and if you guys are okay with a fellow being one of the authors or the author, then fine. Otherwise, I'm not writing this chapter by myself. There's absolutely no way. But that's a good learning experience because if you write like really do a good job on a chapter or review article, you become an expert in that topic, at least on what's available then, and then you just build on that. So that's a good tedious kind of endeavor, but I think from a learning perspective, important. Plus, then you get your name out there too, into the publication field. How do you get invited to do things? Not because you're taking care, not because you're doing 1,000 surgeries. Who cares how much surgery you're doing if no one knows who you are, right? So how do you get known? You'll work at academic centers. You don't have to work at academic centers. Start to publish, get involved in publishing, get involved in committees at whatever organizations are in your area. And that's how you get recognized. And then people start to know you and they start to invite you to things. And then you get to travel the world and do all kinds of cool stuff and meet all kinds of cool people, right? And that's what I tell my junior faculty here, because a lot of times they come on here, they were fellows. They know that all the fellows, I work with fellows, I'm never really a first author on anything unless it's a randomized trial. So it's always, our papers are always the fellow first. So there's no more Leitao at all recently, right? It's all whatever my fellow is, I'm the senior author. So then they go come into practice as junior faculty and they want to do that. They want, I'm going to do this project, but I'm going to have a fellow do all this stuff and they'll be first and I'll be senior. But that doesn't help. You're going to be a senior author with an unknown name. You want to put out a few papers with you as the first author so that things get quoted with you at all. Okay? That's how people will know who you are. And that means you have to do the project yourself. Because here, if a fellow works on a project, they are the first author. You can't have here a fellow do all the work and collecting the data, and then you write the paper and you're the first author. That doesn't fly here. So if junior faculty, they have to collect the data. They either work with stats or with me to do the statistics, and then they're the first author. And they need to do that at the beginning. And I did that at the beginning. And then that's how I got my first invitation was to Brazil when I was a year or two out of fellowship, my first international invitation, because I had written a couple papers on leiomyosarcoma. So I got invited to give talks on leiomyosarcoma, and the rest just flows from there after that, right? So again, it's such a complex field that we're in, and there's so many opportunities, so many different ways of looking at it, that it's always hard to give one set answer to any particular aspect of what's being asked.
Thank you. You touched a bit
Thank you,
the
Professor.
concept of intellectual honesty, and the next question is about speaking up. Because Dr. Leitao, throughout your career, you have never hesitated to express strong and sometimes uncomfortable opinion on complex and controversial topics, whether in editorials or on international stages, such as your editorial on new staging of endometrial cancer or your ESGO presentation on molecular classification. In a field where consensus is often encouraged, how do you balance scientific rigor, intellectual honesty, and the courage to challenge prevailing narratives?
Yeah, that you have to be and you have to be doing this for a while until you can really feel comfortable doing that, because you have to have some credibility in what you say, right? So you come out of fellowship and you start doing what I did, and you have no foot to stand on, right? So you have to be very careful with that at the beginning. At the beginning, there's a lot more agreeing with narrative, let's just say, or going with the flow, right? But one of my biggest mentors is Dr. Richard Barakat. And he's giving me lots of good sayings, but one of them is like, don't ever be a bobblehead. Do you guys know what a bobblehead is? It's that little doll that the head just shakes. Like they often make it like a sports character, right? And they create the doll and the head's on a spring and it just bobs. That means that if you get asked to do things or you're on a committee, you're going to a meeting and you've asked, don't just sit there and agree with everything that's being said. You don't also have to disagree with everything just to be disagreeable. But if you really have something to say that's not going in line and you have support for it because you know what you're talking about, you should feel free to disagree with what's being said. Being involved on lots of different committees, being involved in GOG, seeing how things work. We're part of the NCCN. I know how ESGO guidelines work. It's just a group of people who think they know, it's just their interpretation of the data. That doesn't mean it's right interpretation of the data. And if you know the data and you feel differently, you should be able to speak up. Because if people start to just agree to one thing, we don't move forward. You have to challenge. Science is constant re-challenging of questions, right? Retesting the hypothesis. That's all that is. That's what statistics is. People, and you have to know statistics, by the way. In order to have these conversations, and you don't know statistics or how to interpret these papers, there's no way you could ever say anything. Because someone who might know that stuff is going to tear you apart. So you have to have a strong foundation in statistics. You don't have to do them yourself, but at least know what they are really well. Understand the data that you're using. Have a foundation of data, not just one paper that you're going to quote. Because my fellows do it all the time. Well, having a conversation, they'll quote me the last paper they read. I'm like, what are you talking about, dude? That's one paper. There's like 20 others that are 1,000 times better. And in composite, your message is incorrect. Okay. So you have to have that foundation to then be able to speak up on these things and have some experience built over time to be able to do that. And then be willing to realize that the people making these recommendations, the FIGO board, the ESGO people, the NCCN people, they're no different than me. I am one of those people. I am there. They're just coming up with what the group majority feels should be the recommendation. And in some environments, it's whoever speaks the loudest sometimes that leads to that recommendation. And then, yes, they have review boards and independent thing. Give me a break. It all comes back. If there's any discrepancy, it's whoever speaks the loudest, whoever's the boss or the professor makes the final decision. I've been there. Okay. So knowing that background, I no longer I mean, if it makes sense, then sure, that's a good guideline. Guidelines are for people who don't read. Okay. That's my view on guidelines. It's for people who don't know the literature and want somebody to tell them what to do. That's what guidelines are for. I say we write the guidelines and the next day we're doing something different. Okay. And that's what makes this exciting. And something different isn't always something better either. So you always have to, you don't always have to do something different. Sometimes something is the right thing to do, right? But when it doesn't make sense and you realize that it's being a little too premature, and when you realize that it's really not what they're saying because there's still a lot of limitations in that data they're using, you have to speak up. Because if the whole world just bobbed their head to this 2023 FIGO staging thing, then that's what we'd be using now. And it's not a good system. It just isn't. For staging, stage is anatomic spread. I don't want to get hung up on this right now because I'll speak for another 2 hours on this, but stage is a factor of prognosis and it's based on anatomy. That's it. Everything else just modifies that risk. You don't incorporate that into stage because every 6 months you have to change it then. If you're using molecular, there's something coming out every 6 months that's associated with prognosis. You know what I mean? So when does the staging system stop changing? Then how does a patient know how much the cancer is spread? You know what I mean? That's what staged patients also, no one talks about. To them means something. Patients want to hear that they're stage 1. To them, it means that it's caught early. But in some cancers now with this new thing, there's never a stage 1. It starts at stage 2. So there's never a stage 1 phase of their cancer. It's stage 2 because they're serous carcinomas. Are you out of your mind? Does that make sense? If you want to talk about a nomogram for risk, that's different. That's not stage. Stage is usually part of a nomogram for prognosis, right? Put in stage, put in age, put in whatever molecular thing you want to put in, and then you get a risk score. And based on this risk score, here's your percentage risk of recurrence. That's a different concept. And that should not ever be impacted into stage. And the molecular stuff too, it's the next new shiny toy. You have to know all the data on molecular and be able to interpret that to realize that it's very early on, okay? The TCGA is very different from what we do now. TCGA was high-level molecular next-gen sequencing data, okay? We're using now approximates of that, but using surrogates that are not perfect to nowhere near perfect to TCGA classification. That was a whole different thing. Copy number low and copy number high is not p53 mutant and whatever and no specific. Those are different things. I mean, to be copy number low and copy number high was based on sequencing, you know what I mean? And copy number, actual alterations. So you have to understand that. And then to be so naive to think that 4 stages is good enough, but not 4 molecular groups is good enough. Come on, let's be honest. I mean, so we've now figured out endometrial cancer, and then we know the answer. And if that's what we do, then we'll stop learning, right? If you say, "Oh yeah, this is it, we know it now. Everybody's 4 groups. We're done." Are we really done? Really? Of course we're not. So that's my view of this. Okay. I always like to also do new things. That's the uterine transposition. Keeps me happy. I mean, to do a hysterectomy sentinel node mapping with the robot, I do it with my eyes closed. I watch the fellow do it most of the time. Whatever, you know, it's whatever. I get excited about having these conversations and doing things like this, and then doing new things and complex things. You know, that's what excites me the most. And then training the fellows to do the simpler stuff is also fun watching them. But, you know, I could care less if you do periodic node dissections or not. Do it. I don't know, whatever. You want to do open surgery your whole life? Just whatever. I think that's a disservice to patients, but I don't care. You want to do straight sticks? Laparoscopy? Be my guest. I don't care. As long as you don't open patients. Do whatever you feel comfortable doing. Just don't try to tell me that it's better. It's better for you, not better for me. And I'm not telling you to use the robot either. I'm telling you why I think it's better, but you don't want to use it. I mean, if you don't have access to it, there's no choice, right? But if you have a robot that you can use, you're trying to tell me that laparoscopy is better without it, you're lying. Or you just don't have enough experience on it, right? So, and then at the same time, what I also learned from Dr. Barakat is like, if you are doing something new, like when I started doing a robot, I used to say, this is so much better than straight stick. He's like, don't do that, because you don't know that it's better because you haven't really done a randomized trial, right? And then 2, it's better in your hands. And so what you should do is instead of say it's better, you should just show what you're doing, show your outcomes, and then let people make their own decision about that, you know? Because all you're going to do by saying that robot's the best and it's better surgery is just going to piss off all the people who don't have access to the robot. And then what's going to happen? They're going to be defensive, right? And they'll be like, well, this is why the robot sucks, right? Because of this, that, or the other thing, and straight sticks is so much better and it's so much cheaper and all that stuff. That doesn't progress by doing that. So when you do things in your career, you should never try to put other things down. You should say, this is what we did. This is our experience. This is why we think it's better. And you can be your own judge of it. Okay. And that's another thing why all this stuff with molecular and staging is, you have to think about it. Is this really better? It's not better. Think about, how does this really change the molecular based stuff? How does that change anything? Tell me. Tell me where you know you have a stage 1 endometrial at p53. Well, first of all, is it IHC or you do molecular or you do genetic sequencing? They're different, right? And there's a 10% error rate. They're not 100%, right? And what about when the p53 IHC is equivocal? All right. So, and then you have a stage 1, surgically stage 1 endometrioid that happens to be p53. Where is the data that treating that patient differently is going to make a difference? Yeah, sure, they have a worse prognosis, but we just had this conversation today about another case. There's a 20% risk of recurrence. They should probably get chemo. But we did that trial and it showed no better. No, the recurrence rate was not different. So just because you have a recurrence risk or a worse prognosis does not mean that that thing is predictive for you to make their life better, right? So that's what you have to think about. And that's when you look at all these data on these things, you realize that it's not as great as people are trying to make it seem. And sometimes people want to be the new people with the new toy to try to push that message too prematurely. There has to be some thought to this. This is serious stuff we do. It isn't so that I can get another publication, you know, or say, look at this new thing that we've created. It's so wonderful. No, it's not. And here's why. And I got the data to support it. Anyway, I get long-winded sometimes. Sorry.
No, thank you. It was a very complete answer.
Yeah, it was very interesting.
You also
So
have to,
we,
another thing, just on that real quick, in terms of intellectual honesty, you have to be able to assess what other people say and not always think that you're right. And a lot of times somebody will say something at a tumor board that I think is incorrect, but I'm like, I don't speak up because I'm not 100% certain. I go in and I look that up, and there was some point to that. So you have to be able to change your mind or modify your opinions, and especially when stuff you're not 100% sure of, you know what I mean? So if somebody says something that you aren't sure of, don't speak up just because, at your institution, we do it this way, and that's why you should do this. Say, you know what, let me go read about this and really do a deep dive into what was said, right? And then you'd be surprised that maybe you weren't correct. And you have to be willing to change that. My example is when I left fellowship doing lymphadenectomies. That's it. Sentinel node mapping was not a thing when I finished fellowship. I learned that when I came back to Sloan Kettering as a faculty. So when I left here training, I worked somewhere else for 3 years, and I did node dissections for endometrial cancer, pelvic and paraortics. That's how I was trained. Everybody got pelvic and paraortics. I come back here to do SLN mapping. I was so fixated that lymphadenectomy was so important that we were missing things with SLN. I had such big arguments with Dr. Aberustam at the beginning because he was here for a few years. He's the best. And then as you start to sit there and really look at it and think about it, you realize that he had something, right? You start looking at the data and you start saying, this really is probably the better than what we're doing to patients with lymphadenectomy. You have to be willing to change how you practice based on evolving. You have to be willing to read, willing to say, maybe, you know what, I wasn't right then. It's not because you're a dumb person or whatever. It's just because you were trained one way and taught one way, and now you have to realize that things change over time, and sometimes they change for the better. Sometimes change is not better. So I'm willing. I don't ever speak up unless I have a lot of data, and even then I can be wrong, of course. And I always tell my fellows, if I say something to you, don't just take it at face value. Go read about it. And then if you find something that is different from what I said, come back. We'll have a conversation about it. And we'll discuss what you read and why you think it's not what I said might not be correct. I always learn. I continue to learn all the time. Anybody who doesn't want to change their mind and is so adamant about what they say, it's probably not the best person to listen to.
Yeah.
Thank you. Maybe most of us
So-
were at the beginning of our career and we're a bit afraid of saying
I know.
something.
Yeah,
to-
I'm just a dummy, so I grew up in Newark and whatever. I've gotten into a lot of trouble, trust me. No matter what I do now, early on in my career, I had my boss, Dr. Barakat, was my chief. He took me aside plenty of times to tell me to chill out. All right. And then I would sometimes say something because I read like 2 or 3 papers, and then he's like, well, you missed a few of these papers. Maybe you should go back and read about this before you start talking about it again next time. Or you should probably not say it the way you said it. So it's a learning, that aspect, like surgical learning, that aspect of how to speak about data and interact is also a learning process over many years. And I am nowhere near where I should be probably because I just have no filter sometimes. I just say what I think and whatever. Sometimes it comes across the wrong way, but that is also a big learning process that you learn over time. But you have to be willing to do that. You have to you have to read, you have to know stats, have that big, strong foundation so that when you say something, have published on it even. So when you say something, there's credibility to it, right? Or at least people say, well, let me think about what he's saying. Maybe you might still not agree with what I said, but at least it stimulated some thought. And right. And that's how we move things forward. And then, like I said, fellas, sometimes we'll go read it. Like, here's an example. We don't ever biopsy uterine masses because we're afraid of sarcoma seeding and all that stuff, right? And so somebody said they did that at our tumor board, and I go, who the hell did that? I must not have been here for that recommendation. And then Aberustam goes, well, there was this trial, and I didn't know about it, that they were biopsying and it seemed to be okay. So I'm like, oh, I read about it. So guess what we're doing now? I have one of the fellows working with me. It's going to be a quality improvement. We're going to pull all the data on biopsying uterine masses to see what the data shows. And then we're going to see if we can integrate that into MSK to biopsy uterine masses that might be suspicious, right? Everyone always says you can't do that, right? But actually there is some data that says it's probably okay. And it might be helpful in some situations, right? So I'm always learning, always learning. I always want to learn because otherwise you get bored. If you do the same thing for 20 years, you're doing the wrong thing. One thing I've always hated is when I went to Newark, especially when I was young, but you go there, a new environment, different hospital. I came from Sloan Kettering training. It's a very different place where I went to work. It's an inner city hospital. And then, I was like, can we try to do this here? I started a robot program there. That's where I first learned robot. And then you get the message saying, oh, we've always done it this way here. I'm like, well, if you've always done this for 20 years the same way, maybe it's time to change and think about maybe changing what you're doing because nothing ever lasts 20, 30, 40 years. Some things do, but most things don't, especially when we're talking about surgery and medical care. So anyway, okay, I'm done with that.
Thank you. Thank you.
So thank you for your insight, and we can move forward with the next question, which comes from Nicole Chris from the Western Australian Gynecological Cancer Service in Perth, Australia.
So thank you. I think we've heard about what excites you at work.
Yeah.
But outside of your clinical and academic life, what activities or aspects help you recharge your batteries, maintain your balance, and how important do you think that is in sustaining a long and demanding career like we all want?
Oh yeah, for sure. That's very important. I'm also fortunate to work in a group of 15 people, so I have 14 partners, so that makes work-life balance a lot easier. I'm only on call 2, 3 times a year. So I also don't back up a general OBGYN department, so that makes calls even better. I have fellows that do a lot of work, so I think obviously you can try to find a work environment that is conducive to having a good balance, but that's not always the case. But it is important to try to keep balance. I think that when I'm outside of work, I'm outside of work. We have a call system where it's one of us covers all of our patients for a weekend. I don't do anything work related on a weekend. If a patient calls, they all know that they get my partner or the fellow. So you have to set boundaries with patients too. Otherwise, you don't get a balance. And I've noticed that from traveling all over that a lot of physicians give patients their cell phone number, especially their private patients. I find that to be a huge mistake. It's not that you don't care about patients. It's you have to have boundaries, right? Otherwise, you're working 24/7. You're never not working. If a patient has access to you with your cell phone number, I find that a huge mistake. So, and it's the expectations. As long as you tell patients this is how it works here. I'm not on this weekend. My partner's covering. If there's any issues, they'll call you. Patients understand that. They also have lives themselves. So you have to set boundaries with your patients and boundaries with your colleagues to say, I'm not checking any emails this weekend. I'm not on call. If you need to call me for some emergency, you call me on the phone. If I see a phone call, then I'm going to pick it up, right? But I'm not checking emails. You email me all weekend. I'm not responding. That's it. They know I don't respond. If I'm away traveling, I may or may not respond to some things. That's it. I have a partner covering, I have fellows covering. That's it. And when I'm home, I'm home. I don't really do anything work related when I'm home unless there's a deadline. Like I have a talk to finish, I'm leaving tomorrow or something like that. Or I do a conference call at night just because of hours. Other than that, when I'm home, I'm home. I'm home with my kids. I'm home with my wife. I work out. I play pickleball. I play paddleball. I do volleyball in the summer. I'm on a softball league. So I do a lot of that stuff on the side. I love just going to see my kids at their college. We travel as much. We travel 2 or 3 times a year with the family. That's it. You just got to make time for that. You got to make that as important of a focus as your job. The only thing that's a little hard to control is what environment you work in. How easy is it to do that? If you're a solo practitioner and you have no coverage, I don't know how anybody lives a life that way. It's just, I find it impossible. I have friends that do that in general with GYN. I'm like, I don't know how they do it, to be honest with you. And that's why people burn out. Set up networks with other colleagues. So I think if you're a solo G1 oncologist, you got to set up connections with the surgical oncologists to help cover patients so that you have time off on weekends. You got to take time off on the weekends. I would try to not be on, and when you're not on call, just don't do anything work related at all. Focus on not work stuff. Sit on the couch and watch TV. I don't care. Read a book that's not related to what you do. Okay. But when you're at work, like for me, my like Monday through Thursday and Friday, regular day, it's work pretty much. When I go home, I go home, but I get up at 4:30. I get home at 11 o'clock at night. So, I go home to go to sleep during the week. But come Friday after clinic, because I have clinic on Fridays, I usually finish around 5 or 6. That's it. I'm done until Monday morning. Unless I'm on call. That's it. I'm done. I check no emails. I tell the fellows, if there's an emergency that you need to talk to me, you got to call me. That's it. I'm not checking emails. I'm not responding to anybody. If I'm away on vacation, I am not responding to anybody, period, end of story. And you have to set those limits. None of my patients have my cell phone. I always tell them, do not call. Some will ask, I'm like, no, you call the office. We have a whole process that's safe. I tell them, when I do stuff where they get admitted, open surgery stuff, I tell them, I might not see you while you're in the hospital. The fellows will take care of you. I can see everything that's happening. If there's an emergency, I'll come back, but I'm not going to take care of you. I might not see you while you're here if everything's going fine. Like that, I don't have to make weird times to come see them after operating down the street or being in clinic on 53rd Street. And I tell patients also, if I'm doing surgery on Wednesday and I'm leaving the next day for a trip or a meeting, I tell them I will be out of town starting Thursday until Tuesday the next week. My partner so-and-so is covering me. If, God forbid, an emergency happens, it'll be them taking care of you. I will not be available. That's it. But you have to let them know that too. You can't operate Wednesday, leave Thursday, bad complication Friday, like where the hell's my surgeon? Right? So I guess what I'm trying is you have to set boundaries at work and with patients so that you can have that time protected for when you're not at work. And then find stuff you love to do. I like the activities and spending time with my families. I play poker once a month with my friends. I have a poker team. We play cards. You know, I live an hour away in New Jersey with no traffic. That sucks, the commute. But when I'm there, I'm away from work. And it's very outdoorsy. I have quads. I go fishing, you know. So I spend as much time as I can doing non-work related stuff. Sometimes you have to take a little bit home, but try to limit that. I think some people get so over, like I said, I've been with surgeons and we're traveling and they're at a meeting somewhere and they're getting a call from their patient and they're talking to their patient about what to do while, you know, they're in a different country at a meeting. I mean, that's not, I mean, give me a break. You know what I mean? So, and I listen, I work in MSK, we're on the Upper East Side of Manhattan. We have some very well-to-do patients here. So even those patients, I give them boundaries because next thing you know, they expect you to answer the call and expect you to be seeing them every day in the hospital. I don't care about that. You know, I tell every single patient, I don't care who they are. And trust me, as you can imagine, we have some pretty well-to-do people here. This is how it works, and this is how it works for everybody. That's it. Oh, you're muted. You're muted, Nicole.
Sorry, I
Thank you,
said
Professor.
thank you very much. I think that's great advice for us early on.
Thank you, Professor. The life balance is very important to prevent burnout. And the last question comes from Naya Seminaro, Weill Hebron Hospital Campus, Spain.
Thank you very much for all your questions, Dr. Leitao. My question is regarding advice to your younger self, and it's if you could give one piece of advice to your younger self at the start of your training, what would it be and why?
Well, probably not to go into OBGYN. That'll be the first one. Nah, I take that back because it actually worked out. I can't say that now. I don't know. It's a good question. What would I say to my younger self? I don't know. Maybe do some of the things that I did that I can't really reveal that probably I shouldn't have done. On the outside of work kind of stuff. Just realize that I don't know as much as I think I do at that time and have the attitude that I have now of being more open to other opinions and realizing that you don't know everything yet and that you should be a little more receptive to different opinions, that you aren't as great of a surgeon as you think you are, and that this will continue to get better. But just realize that doesn't mean that you're not a good surgeon. It just means that there's a lot of growth still to be had and you have to continue to learn. I guess that's it. I mean, I don't regret anything I've done. And obviously, whatever I've done, I've done pretty good. I'm at a great place. So I've obviously done, I think, some things right, but I think a lot of what I told you guys today about just reading and being more open to other opinions and other views on data and other views on how to practice is always something to keep in mind. I think sometimes when you're earlier on, you have some knowledge, but you don't have the breadth of knowledge that you should have to make some of the decisions and opinions you might have. And oftentimes your opinions and decisions are based on what your faculty are telling you. So even as a fellow, I said, yes, thank you for telling me that. And then I went and looked things up. And then I went back and did challenge some folks. So, but you have to do it with the data. So I don't know I don't know. I guess that's what I have to say is just be more open and realize you're not as great of a surgeon or you know as much as you think you know. It might have made some of my interactions a little more pleasant back then, I guess.
They're very good advices. Thank you.
Exactly, great advices. Dr. Leitao, thank you for sharing your experiences and knowledge. Your work stands as a reminder that innovation, empathy, and persistence can transform not only patient outcomes, but the future of our specialty. We learned so much from you. Thank you.
Thank
On
you.
behalf of the International Journal of Gynecological Cancer editorial fellows, we are deeply grateful for your time with us today and for the inspiration.
And, so this has been the IJGC Mentor podcast, and thank you all for listening. And thank you, of course, Professor Leitao.
It was my pleasure. This was fun. Hopefully it was helpful.